Welcome back to Anatomiqa. In this session, we will be discussing the details of the different arches, which include the following: formation, parts, factors maintaining the arches, and the clinical anatomy. The learning objectives of the session are: enumerate the types of arches of the foot, explain the structure and functions of the arches of the foot, compare and contrast the medial and lateral longitudinal arches of the foot. Describe factors maintaining arches of the foot with its functional importance. Explain the anatomical basis of flat foot. Explain the anatomical basis of club foot. Explain the anatomical basis of metatarsalgia, and explain the anatomical basis of plantar fasciitis. The functions of the arches of foot. We can imagine the whole foot as a single functional unit, as a weight bearer and as a lever. The foot has several important functions. The first function is to support the body weight. The arches help in proportional distribution of the body weight to the ground. A person possessing a body weight of 120 kgs transmits 60 kgs of weight through each foot in standing position. This 60 kgs is initially received by the talus in each foot. Thereafter, the weight is distributed equally through the posterior and anterior parts of the foot. About 30 kgs are distributed to the heads of 5 metatarsal bones in the anterior part. Heads of 5 metatarsal bones possess 6 bearing points. The first metatarsal bone has 2 sesamoid bones beneath it, transmitting equal parts of the weight. So, each bearing point transmits about 5 kgs of weight. Therefore, the first metatarsal head takes up double the load than other metatarsal heads. The bulky size of calcaneus transmits 30 kgs of weight through its heel to the ground. The second function is to act as a lever to propel the body forward in walking and running. If the foot possessed a single strong bone instead of a series of small bones, it could sustain the body weight and could act as a rigid lever for forward propulsion. But with such an arrangement, the foot could not have adapted itself to uneven surfaces, and the forward propulsive action would depend entirely on the activities of the gastrocnemius and soleus muscles. With the smaller bones, the foot is segmented with multiple joints and act as a segmented lever. It is pliable and can adapt itself to uneven surfaces. Moreover, the long flexor muscles and the short muscles of the foot also can act on the bones of the distal part of the foot and toes and greatly assist in the forward propulsive action of the gastrocnemius and soleus muscles. The lumbricals prevent the toes from buckling when the toes are pulled by long flexors. Plantar concavity of the arches protects the plantar vessels and nerves from compression. In flat foot, the nerves may be compressed, producing pain in the metatarsal region of the foot and radiating towards the toes, which is called metatarsalgia. When the foot is on the ground, the arches flatten slightly, but when off the ground, they restore the original contour. Therefore, the foot acts as a springboard which helps jolting and jumping from a height. The inverter and everter muscles of the foot can produce a shift of weight distribution among the heads of the metatarsals in order to adapt the foot while moving on an uneven surface. The amount of weight distributed between the metatarsal heads can change on uneven surfaces for better movement. When we observe the imprint of a wet foot on the floor made by the person in the standing position, we can see that the heel, the lateral margin of the foot, the pad under the metatarsal heads, and the pads of the distal phalanges are in contact with the ground. The medial margin of the foot from the heel to the first metatarsal head is arched above the ground because of the medial longitudinal arch. The pressure exerted on the ground by the lateral margin of the foot is more at the heel and the head of the metatarsal of the fifth digit. The pressure is least between the 2 points because the lateral longitudinal arch is at a lower level. The transverse arch involves the bases of the 5 metatarsals and cuboid and 3 cuneiform bones. In a foot, only half an arch or dome is present, with its base on the lateral border of the foot and its summit on the medial border of foot. Because of this, when the medial borders of the 2 feet are placed together, a complete dome is formed. From this description, it can be understood that the body weight on standing is distributed through a foot between the heel and 6 points of contact with the ground, namely the 2 sesamoid bones under the head of the first metatarsal and the heads of the remaining 4 metatarsals. In the young child, the foot appears to be flat because of the presence of a large amount of subcutaneous fat on the sole of the foot. When we observe the footprint, both medial and lateral borders are seen because of the flat foot. Coming to the structure of the arches of the foot, a segmented structure can hold up weight only if it is built in the form of an arch. The foot has 3 such arches which are present at birth: the medial longitudinal arch, the lateral longitudinal arch, and the transverse arch. The arch will have a summit, which is the highest point of the arch, and 2 pillars, the anterior pillar and the posterior pillar, which is present at a lower level and touches the ground when the foot is on the ground. The bones of the arches are formation of the arches. An examination of an articulated foot or a radiograph of the foot shows the bones that form the arches. Let us discuss the structure one by one. Medial longitudinal arch consists of the calcaneum, the talus, the navicular bone, the 3 cuneiform bones, and the first medial 3 metatarsal bones, including 2 sesamoid bones beneath the first metatarsal head. The summit of the arch is the point which is at a higher place and is formed by trochlear upper surface of the talus. The posterior pillar is formed by medial tubercle of the calcaneum. The anterior pillar is formed by the heads of medial 3 metatarsal bones. The most vulnerable part of the medial arch is represented by the head of the talus, which acts as the keystone. In front, it articulates with the navicular bone. Below, it articulates with the sustentaculum tali of calcaneum and by the spring ligament between them supporting the head of talus. The arch is more resilient because of a greater number of bones and joints. The lateral longitudinal arch consists of the calcaneum, the cuboid, and the lateral two metatarsal bones. The summit of the arch is low and lies at the subtalar joint. The posterior pillar is formed by medial tubercle of calcaneum where both the longitudinal arches meet. The anterior pillar is formed by heads of 4th and 5th metatarsal bones. The most vulnerable part is formed by the calcaneo-cuboid joint, which is supported from below by the long and short plantar ligaments. This arch is rigid in nature because of a smaller number of bones and joints. Transverse arch. The transverse arch consists of a series of arches, anterior and posterior. The anterior transverse arch is formed by the heads of the metatarsal bones. It is a complete arch since the heads of the 1st and the 5th metatarsal bones comes in contact with the ground, forming two ends of the arch. The posterior transverse arch consists of the bases of the metatarsal bones, the cuboid, and the three cuneiform bones. The posterior transverse arch is incomplete, each foot presenting a half dome with the concavity directed downward and medially. When the medial borders of both the feet are approximated, a complete transverse arch is formed. Now, with this background of structure, let us discuss what are the factors or mechanisms maintaining these arches of foot. We will understand the factors maintaining arches better if we first look at the design of any bridge, revealing the following engineering methods used for its support. The shape of the stones. The most effective way of supporting the bridge is the stone to be wedge-shaped with the thin edge of the wedge directed towards the inferior surface. This applies particularly to the important stone that occupies the center of the bridge and is referred to as the keystone. Imagine the same architecture with the arch supported by the wedge-shaped bone where the thin edge is directed towards the plantar surface which forms the summit of the arch. Next important point in maintaining the bridge is the intersegmental tires. The inferior edges of the stones are tied together. This is done by interlocking the stones or binding their lower edges together with metal staples. This method effectively counteracts the tendency of the lower edges of the stones to separate when the arch is weight-bearing. In the arches, the metal staples can be compared to the plantar ligaments holding the adjacent bones together. The next factor is the use of the tie beams. When the two ends of the bridge is far with insecure foundations at either end, a tie beam connecting the two ends prevents the separation of the pillars and consequently prevents the sagging of the bridge. The long tendons extending through the sole can be compared to the tie beams in the arches. The last factor helping the bridge to be intact is the suspension bridge. Here, the maintenance of the bridge depends on multiple supports suspending the bridge from a cable above the level of the bridge. The tendons extending from the leg and inserting in the foot could be compared to the suspension of the bridge. Using the bridge analogy, we can now examine the methods used to support the arches of the feet. Let us discuss the factors maintaining the individual arches. Maintenance of the medial longitudinal arch. Shape of the bones which maintains the medial longitudinal arch are sustentaculum tali of calcaneum, which holds up the talus, the concave proximal surface of the navicular bone articulates with the rounded head of the talus. The slight concavity of the proximal surface of the medial cuneiform bone articulates with the convex distal surface of the navicular bone. The rounded head of the talus is the keystone in the center of the arch. The intersegmental tires maintaining the medial longitudinal arch are short and long plantar ligaments, larger and stronger than the dorsal ligaments of the foot, where the inferior edges of the bones are tied together by them. The most important ligament is the plantar calcaneonavicular ligament. The tendinous extensions of the insertion of tibialis posterior muscle also forms another important intersegmental tire. The tie beams tying the ends of the medial longitudinal arch together are the plantar aponeurosis, the medial part of the flexor digitorum brevis, the abductor hallucis, the flexor hallucis longus, the part which is medial in the flexor digitorum longus and the flexor hallucis brevis. The suspension of the medial longitudinal arch is brought about by the following structures: the tibialis anterior, tibialis posterior, and the medial ligament or deltoid ligament of the ankle joint. Coming to the maintenance of the lateral longitudinal arch, the shape of the bones maintaining the lateral longitudinal arch are minimal shaping of the distal end of the calcaneum and the proximal end of the cuboid. The cuboid is the keystone of the lateral longitudinal arch. The intersegmental tires maintaining the lateral longitudinal arch, where inferior edges of the bones are tied together, are by the long plantar ligament and the short plantar ligaments. The tie beams of the lateral longitudinal arch tying the ends together are the plantar aponeurosis and the following muscles: the abductor digiti minimi, the lateral part of the flexor digitorum longus, and lateral part of the flexor digitorum brevis. The suspension of the lateral longitudinal arch is brought about by two muscles, peroneus longus and peroneus brevis. Now coming to the maintenance of the transverse arch, Shape of the bones maintaining the transverse arch are the marked wedge shaping of cuneiform bones and the bases of the metatarsal bones. The inferior edges of the bones of the transverse arch tied together by the intersegmental tires are deep transverse ligaments, the strong plantar ligaments, and the origins of the plantar muscles from the forepart of the foot, the dorsal interossei, and the transverse head of the adductor hallucis. Tie beam tying the ends of the transverse arch together is the peroneus longus tendon. Suspending the arch from above are the peroneus longus tendon and the peroneus brevis. You can pause the video to go through the differences between the medial and lateral longitudinal arch. We will now discuss the clinical problems associated with the arches of the foot. Pes planus or flat foot is a condition in which the medial longitudinal arch is depressed or collapsed. As a result, the forefoot is displaced laterally and everted. The head of the talus is no longer supported and the weight of the body forces the head of the talus downward and medially between the calcaneum and the navicular bone. When the deformity has existed for some time, the plantar calcaneo-navicular and the medial ligaments of the ankle joint become permanently stretched and the bones change their shape. The muscles and tendons are also permanently stretched. The causes of flat foot are both congenital and acquired. The effects of flat foot are: the person has clumsy shuffling gait due to the loss of spring in the foot, makes the foot more liable to trauma due to less shock absorbing function. Plantar nerves and vessels will be compressed due to loss of concavity, leading to neuralgic pain. This condition is called metatarsalgia. Pes cavus or high arched foot or claw foot is a condition in which the medial longitudinal arch is unduly high. Most cases are caused by muscle imbalance. In many cases, it may result from poliomyelitis. High arched foot occurs because of contracture at transverse tarsal joint. When a person walks with high arched foot, there is dorsiflexion at metatarsophalangeal joint and plantar flexion at interphalangeal joints. Talipes or clubfoot. The clubfoot may be congenital or acquired. Talipes are of different types. Talipes equinus. In this condition, the foot is plantar flexed and person walks on the toes with heel raised. In Talipes calcaneus, the person walks on heel with the forefoot raised. In Talipes varus, the foot is inverted and adducted. Person walks on outer border of foot. In Talipes valgus, the foot is everted and abducted. Person walks on inner border of foot. In Talipes equinovarus, foot is inverted, adducted and plantar flexed. Hallux valgus. The big toe is deviated medially at metatarsophalangeal joint. The head of first metatarsal is prominent, which rubs on the shoe. This leads to the formation of protective bursa called bunion on the medial side of toes. Hammer toe. In this condition, metatarsophalangeal and distal interphalangeal joints are hyperextended, but proximal interphalangeal joint is acutely flexed. Usually it occurs on second or third toes. Plantar fasciitis is the inflammation in the plantar fascia or plantar aponeurosis. It's the most common cause of heel pain. Plantar fasciitis occurs when the plantar fascia is overused or stretched too far. So with this, we complete the session on the arches of the foot. Thank you for watching till the end. If you find the video useful, like and share it with your friends. And if you have not yet subscribed, subscribe to the channel.